Hewett, who I think to most of us probably doesn't need an introduction. He is, I think, Tim, you consider yourself a general scientist, right?
Absolutely.
Yeah. So Tim is a very interesting guy because he is actually a physiologist. He trained in cardiac physiology, believe it or not, before he then really got into biomechanics and physical therapy. And he is one of those people who really can do anything from computer modeling to a clinically relevant translational research in the labs, but also he has spent a lot of time doing at the time, extraordinarily unusual and novel thing. He actually created a very large prospective cohort of high school kids after ACL injuries and followed them with their functional parameters and followed them with their return to play parameters, etc. And he did that in Northern Kentucky out of his time when he was at Cincinnati Children's Hospital. From there, he went to Ohio State University, the Ohio State University, where he basically built their biomotion lab in their new sports center back then. This is almost 15 years ago now too, right?
Yes, correct.
And then from there, he went to the Mayo Clinic, where he again built a brand new lab and was involved with their sports performance. And then is over the last 2 years has basically gone into private consulting for other research institutions, but also for professional organizations. Tim is one of these people who are mentor to many, and a teacher and friend to a lot. He really has gone out of the way over the last 20 years, basically, to educate people on injury prevention, on injury recovery, predominantly from the ACL. He is the most cited, social media cited expert on the ACL. And we are extraordinarily fortunate to have him not only as a consultant working with us on the sports performance center that we are building, but he is also giving us a talk today about how he approaches ACL and PCL injuries biomechanically, how he understands the knee. So without further ado, Tim, tell us what your insights are here. We are dying to hear this. Thank you.
Thank you very much for that extremely kind introduction, Christian. One of the best people I've ever had the pleasure and honor to work with over many years. So I've been studying the ACL, the PCL, and knee injuries for many years now. And this is a knee dislocation. That was, by the way, I am a Cincinnati, Ohio native. This is my Ohio State Buckeyes. When I was in the kindergarten, the Buckeyes won the national championship. This is them winning the national championship in 2001. And basically that is a devastating knee injury. Now, this one, I don't know if this is going to actually play. Let's see if you can see this. This is from my YouTube channel. This is Michael Owen rupturing his ACL. As you can see, that's a non-contact mechanism, this dynamic valgus mechanism that we see so very often, if not always, during an ACL injury. And here's another example. This is our beloved Joey Burrow last year. And this is him tearing his ACL through what you can see is a pivot shift mechanism, actually. So again, 3 different mechanisms for this kind of crazy injury that we deal with. on a regular basis, and we've studied for many years. So again, what you'll see there is you'll see his knee pivot shift as you see it reduce back into place. Now, interestingly, as you guys learn from Dr. Latterman, an expert like Dr. Latterman is basically let me do that. And what you'll see from let's see if we can get that back up. What you'll see from that example is that just as you would do in a clinic with a pivot shift exam, what you're doing is you're forensically reproducing the luxations that occurred during the injury. And so, for example, with a pivot shift exam, which by the way is the #1 most clinically specific, if you have a pivot shift exam, you have an insufficient ACL. So 100% of the time. So it's the most clinically specific test that you'll utilize in your armamentarium. And basically what we're going to talk about is what it does, what that does. But it's basically forensically reproducing the luxations that occurred in the knee to rupture those ligaments. So let's quickly go through some knee anatomy. The knee is an amazing joint. It's the largest and one of the most complex joints in the body, and it consists of both the tibiofemoral and the patellofemoral joint. And the knee provides this large range of motion that allows locomotion and support of very large loads. So what about knee ligaments? How do they function? Well, ligaments have two important mechanical functions. One is to limit the gross motion between the bones. For example, for the anterior cruciate ligament, it limits the anterior translation of the tibia relative to the femur, but also operates importantly in all three planes of motion. It also limits valgus, and it limits especially internal rotation. But maybe more importantly, especially for long-term knee joint health, in the area where Dr. Latterman is such a world expert at the articular cartilage, it limits the micromotion between those articular cartilage surfaces of the medial and lateral tibial plateaus and the femoral condyles. So how do these ligaments function biomechanically? Well, there are three important biomechanical properties that allow ligaments to function mechanically to limit motion. The first is the attachment location. For example, the ACL is attached anteriorly. It inserts anteriorly on the tibia, so it's going to resist anterior translation. And the PCL is posterior, inserted posterior, so it's going to limit posterior translation of the tibia relative to the femur. The other is the just taut length of the ligament. And this is actually challenging. You guys can actually do that better in a clinical situation very often than we can biomechanically, because we very often don't know where our zero position is. But the just taut length controls the motion before the ligament begins to provide resistance to the force on the joint. And then the third and very important property of all the knee ligaments is their stiffness. And this controls the movement after the ligament becomes taut. Well, we need to think, as I mentioned earlier, of the motion of the knee joint in all 6 degrees of freedom. So there are 3 rotations: flexion, extension, ABA deduction, which is going to be so important when we talk about injury, and internal external rotation, which is going to be very important as well when we talk about injury. And there are 3 translations: anterior, posterior, medial, lateral, and compression, distraction. And each of those knee ligaments contributes, and we're going to talk about how they contribute. Now, this is our beloved Carson Palmer, our original number 9, who was taken out by some I think they're always the dirtiest team in the NFL, and they took out in the playoffs in 2005 and ruined our chances to go on to the Super Bowl, which we were sure we were going to go that year. So we've had to wait 33 years to actually get back in the game, and that's coming up in 13 days from now. So stability of the knee. The geometry of the knee provides little stability. It provides the main attribute of the knee is its wide range of motion. So the knee allows us to move, and it is also not very stable from a geometric point of view. We're going to talk more about that. So the stability of the knee joint depends on both these static restraints that we've been talking about, and the dynamic restraints, the musculature, the neuromotor control. And basically this is the static restraints that we see right here and the major ligaments of the knee joint. So what are the major passive restraints, the static restraints to motion? Basically the collateral ligaments, the major ligaments that cross the medial and lateral aspects of the knee joint, and the cruciate ligaments, called cruciate because they cross one another. They're the major ligaments connecting the anterior and posterior aspects of the knee, the tibia to the femur, as we just discussed. So very importantly, the anterior cruciate ligament, it connects the anterior aspect of the tibia to the posterior aspect of the femur. It is the primary restraint to anterior translation and internal rotation of the tibia, first suggested by this amazing man that we all know and love so well, Freddie Fu, and the whole gang from Pitt that did so much to teach us about the knee. And Dr. Fu taught us that the ACL is the primary stabilizer of the knee joint, especially with anterior translation moment. This is another complete knee dislocation, and this is a whole nother talk, but just to show you the rotations that can occur. Now this is, basically I wanted to get across that point of pivot shift exam. The pivot shift is a reproduction of the luxation. So to get a positive pivot shift exam, what you're going to do clinically is you're going to take a straight knee, starting fully extended. You're going to flex the knee, and then you're going to abduct the distal tibia, internally rotate the knee, and that's going to reproduce the ACL rupture. And then as you extend the knee again, it's going to reduce back. And that's the positive pivot shift exam, which is so important. And it's so important that that's done under anesthesia to keep from neuromotor guarding, which again, just as in the playing situation, protects those ligaments from strain and the joint itself from damage. So what are all the contributing primary and secondary restraints? So that Lachman test that everyone knows very well, you've probably seen that, the really bad one that was performed in the MMA ring, where he just kind of played around with it and said, oh, that's an ACL tear. Well, it's not that easy. So knee flexion angle at 25 degrees, the ACL is the primary restraint of that anterior motion. It gives 85% of the restraint, and the secondary restraints are the medial and lateral collateral ligaments. The posterior drawer test, performed at 90 degrees, is going to test for PCL sufficiency. So it is going to be 95% of the primary restraint, and the other associated, the MCL, LCL, and the posterior medial and posterior lateral structures are going to be that remaining 5% when performed at 90 degrees. The valgus stress test, again, knee flexion angle is very important. So at 5 degrees, the medial collateral ligament takes up 57% of the restraint, but at the proper angle at 25 degrees, it's going to be nearly 80% of the restraint to valgus stress. So that's going to test much more effectively the sufficiency of the medial collateral ligament. The varus test at 5 degrees, the fibular collateral or lateral collateral ligament is going to take up 55% of the stress. And at 25 degrees, it's going to be 70%, a better test at 25 degrees. So flexion angles associated with the largest increased joint displacement. So again, this is important, especially for testing the sufficiency of these ligaments. If you're going to test the ACL in this range of 15 to 30 degrees, the ACL plus the MCL. And again, these are internal, external, and abduction rotation values. And it's very important how the knee is set up if you're going to test ACL, MCL, plus the medial and posterior lateral structures. You're going to have to put the knee in the range of 30 and 45 degrees. So ACL tear strength. How strong is the ACL? So the ACL, we know, is this very strong elastomeric tissue. It's very elastic and it has high strain strength. Well, if the data from Ed Grude, a good Cincinnati boy in his own right, he basically showed that cadavers could withstand. This is basically just distracting apart the knee joint, pulling it apart axially along the axis of the femur. He basically showed that 1,735 newtons, or about 400 pounds. Now, Pete Torzilli and the group at HSS in New York City reproduced this, and they actually used slightly younger cadavers, but everybody knows everybody in New York is tougher than everywhere else in the world, including cadavers. They came up with a value of between about 2,200 newtons, which is nearly 500 pounds of force. So it's a very strong ligament. Now, this is with the secondary restraints resected. And Ed Grude and Frank Noyes, they came up with this bumper model of secondary restraint. So you lose the ACL, and what becomes your primary restraints? MCL and LCL. And again, this is important. You'll see in a lot of textbooks this position of no return figure. And what it'll show is when someone's tearing their ACL, they'll have this big valgus stress, this dynamic valgus collapse that we see so often, and the foot's externally rotated. Now, people take that to mean that the tibia, the distal tibia, is also externally rotated. The distal tibia probably is, but what you get with that externally rotated foot and that dynamic valgus collapse of the hip and knee is you get coupled internal rotation of the proximal tibia. Internal rotation is what tears the ACL. External rotation of the proximal tibia actually takes strain off the ACL. So this is an important point to make. So ACL tension and flexion extension is important. ACL, as we know, is two bundles. So that the anterior medial bundle in extension is going to be under more strain. The posterior lateral bundle is going to be under greater strain during flexion, and as with the PCL as well. So ACL basic science, the ultimate failure load about 1,750 newtons. Using young cadavers, Torzilli came up with 2,200 newtons. So again, between 400 and 500 pounds of force to tear the ACL apart. Very strong tissue. The speed and the force affects the type of tear. For example, a low twisting ski injury will elongate the ligament up to 30% before rupture. However, there may be partial ruptures of the anterior medial bundle and leaving the lateral aspect intact. And athletes in soccer and basketball who stop and pivot quickly often have a mid-substance tear, and this ruptures at much lower strains rapidly. This is the load curve for ligament rupture. So in extension, in the y-axis is the load. This is the amount of extension in the joint. And basically what you see is this toe region where there's very little as the tibia is brought into extension. There's very little strain on the ligament. And then you get this very linear region where you're loading up the ACL as you bring the tibia forward, and then rupture, failure. And this load to failure is very often difficult to determine. If you cycle load an ACL, what you get is this hysteresis loop. So as you go through load and extension cycles, it actually takes more extension to gain the same load. So it's a hysteresis loop. And as we stretch it out, it changes the relationship between extension. It takes more extension to create more load, and then it comes back on a different trajectory. Important for testing. Injury epidemiology. There's this number is all over the map. So Frank and Jackson, which is, again, this is a pretty old, this is 20 years old now, told us 100,000 per year. Now the manufacturers who sell a lot of ACL reconstruction kits will tell you this number is something like 350,000. Believe it or not, we're not even sure. And America has the best data in most places. So what we do know, even using 100,000 per year, you're talking about nearly $1 billion in medical costs in the US per year. Mechanisms of injury. We showed you the different mechanisms of injury: contact, indirect contact, non-contact. Well, believe it or not, even in a sport like football, like NFL football, 70 to 80% of these ACL injuries are non-contact in nature. And these injuries usually occur from deceleration, cutting, landing from a jump, and a combination of knee abduction. When I'm talking about knee abduction, the hip and the knee are caving in and the distal tibia is going away from the center of the body, and tibiofemoral rotation, internal rotation and valgus combined with anterior translation, especially of the lateral compartment, occurring at the same time very rapidly. Within 50 milliseconds of foot contact to the ground, ruptures the ACL. So again, very different injuries, very different sports, extremely similar mechanisms of injury. Non-contact injuries in females are a big problem. Why? Because they're somewhere between 2 and 10 times more frequent in female athletes playing the same sports than male athletes. Knee flexion angles are an issue, especially frontal plane valgus is shown very often in these injuries. Importantly, the ACL is a sensor of force and torque. Kennedy, Schultz, Johansson showed us that this is a heavily innervated tissue. And as such, the ACL is not only a sensor, it senses the three-dimensional position of the knee joint, but it also senses the force and torques on the knee joint and adjusts through afferent, efferent spinal level feedback loops. For example, if I tug that ACL forward and someone who's anesthetized, their hamstring muscle turns on to act as an agonist and decrease strain on the ACL. Landing mechanics are important. Knee valgus motion, medial motion is important. Basically, we showed that once you put 29 Newton meters, and Markov's data shows this exactly the same, it puts the ligaments in a high slope length of the stress curves. And Pope showed that 35 Newton meters elicits pain in female athletes. So how are valgus torque related to peak impact forces? The valgus torque go up. The torques are very, on the strain of the ligament is very high, but luckily with training, as we've reported some time ago now, over 25 years ago, we demonstrated that we could reduce both the valgus torque and the peak impact forces and the strain on the ACL with training. So measure movements similar to the knee and during the landing mechanism. So if you're going to look for risk reduction, look during landing or deceleration. And we use this box vertical jump and lateral cutting maneuvers to analyze this. But this is a good picture of that ACL rupture mechanism. It's basically the pivot shift. Pivot out, reduce back in. Again, non-contact ACL injuries across sports, very different sports, very different movements. The contributors are all the same, especially the trunk. Movement of the trunk lateral to the knee joint creates a torque which pushes the hip and knee joint in internally rotates the knee joint, anterior translates the lateral compartment, and ruptures the ACL, regardless of what sport or situation. Knee structures and the dynamic restraints are extremely important. And Christian and I touched on this. We're helping Mass Gen build their new real-time motion capture laboratory. But importantly, the kinematics are crucial when you're looking. So knee motion and axes. We've got the axes, anterior, posterior, so 3 axes and 6 total degrees of freedom of rotation. Gait analysis, you can use the lab to look at this, and we've done a series of studies. Most of this is done with the group at Yale on the triple varus knee. I'm actually getting ready to do a lecture next on this, but this is a very interesting. When you lose those dynamic restraint or those static restraints, it's so important to restore those neuromotor restraints, especially in the triple varus knee. But what you have is problems in all 3 planes of motion, because it took injury in all 3 planes of motion to rupture those ligaments. And this gait, those loads have to be normalized prior to that reconstruction, or you're going to load the ligaments back in the same way. Joint coordinate system by Gruden-Sunte is what we use to measure this motion in the laboratory. These are the knee kinematics during gait. So this is heel strike to toe off. This is normal knee kinematics. So close to 0 or slight recurvatum, peaks out about 20 degrees, then goes down to about 0 degrees. This is a very important point. This is when your center of mass is balanced over your foot base. So basically the loads go down to 0, and then this is swing. But heel strike to toe off, very limited, about 25 degrees of flexion. So this is kinetics, actually looking at the relative, just in the sagittal plane, the flexion extension moments. This is the hamstring at heel strike. So this is going to be primarily hamstring. This is quadriceps. So this is that external extension, or I'm sorry, external flexion moment, which is your quadriceps. This is that 0 point when your center mass is balanced over the foot base. And then this is both kick in of the hammies and the gastrocs. So triple varus knee has extreme functional consequences. The athlete cannot control that. And with loss of multiple ligaments, you get gait abnormalities and chronic unstable knees that lead to a degenerating joint. The good news in all this, basically we've shown in multiple situations that the risk, you can reduce the risk overall with neuromotor training prior to participation between 1/2 and 2/3. All ACL injuries can be reduced, the risk can be reduced by 1/2. Non-contact ACL injuries in females can be reduced by 2/3. And basically with neuromotor training, you can normalize those loads at the knee joint. We use very targeted training, a lot of biofeedback with our athletes, starting proximally, then working distally, getting them to regain control and giving them feedback either in the laboratory with a screen or even with a phone out in the field. And basically, if you look at, can you predict? Now, this is obviously extremely controversial. Have a lot of fun with this on Twitter. Please join us on Twitter, because you tell me you can't predict and a troll pops out. So it makes it very interesting. But what we know is ground reaction force loading is related to ACL injury risk. You have to have that ground force to load up the joint and load up the ACL. What we've shown is with training, we can significantly alter that ground reaction force and significantly alter risk. This was a prospective study. Dr. Latterman referred to this. So we've been studying this cohort in Boone County, Kentucky, where my farm is, for over 20 years. And basically what we showed was, so we tested every single athlete in the county that played basketball, volleyball, and soccer. And basically what we showed is those athletes that flex their knee less. So this is uninjured athletes. These are athletes that we've tested in the lab prospectively Let them go out and play soccer, volleyball, and basketball. And these are those that go into injury. They have about 9 degrees more abduction, so more dynamic valgus on landing and jumping when they're rebounding a basketball set at its maximum height, and about 10 degrees less flexion, which is a more stiff pattern, which leads to more force. Basically, what we're trying to do is bridge that gap between the laboratory and the court, and we've been able to do that over the years to distinguish those kids and put them into degrees of risk. Moderate, lower, moderate, higher risk categories. And what we need to do is screen these athletes, look for those athletes at risk, those athletes who are trunk dominant, who have a lot of trunk motion out of control, which is going to lead to those high dynamic valgus torques. We're going to start proximally on the trunk, work distally. Those that are more quad dominant, we turn on the posterior chain with this assisted Russian hamstring curl, hit the glutes, hit the hammies, make sure they're powered up to reduce their risk of injury so that hopefully we can prevent injuries like this in the future. Wrote a book on this with a whole group of great individuals. I don't make a dime off of it. All the proceeds go to AOSSM for ACL injury risk reduction research. And there's our beautiful city of Cincinnati, home to those Bengals. Please, please, please root us home for this Super Bowl. You do not want the LA Rams. So thank you. I want to thank a whole bunch of people that were involved in this. And I also want to thank Christian and Simon for inviting me to speak to you all today. It was a great pleasure. Thank you very much.
Thank you very much, Tim. That was a great overview. I think coming all the way from the very basic anatomy and how that really connects through the biomechanics into injury prevention and training. The one thing that I always find fascinating is we have focused a lot of our efforts in the last maybe 10, 15 years on starting to introduce some of these injury prevention programs based upon the work that you and others have done. Mm-hmm. And we know that if they are implemented correctly, that they can reduce injury frequency quite significantly.
Yes.
Like with all of these programs, does it matter which one you use?
No, it doesn't matter which one you use. So we published in 2018 a massive group of studies. So we published in the Journal of Athletic Training that year, the NATA's position statement on this, basically very general position statement. It took us about 10 years to do that meta-analysis and systematic review of the existing literature. Basically, we came to the conclusion you can reduce risk of an ACL injury by about 50%, a non-contact injury in females about 2/3. By the way, that was the exact number we came up with when we published our first study in 1999, about 20 years before. Now, since that time, we've done multiple studies. So we did a meta-analysis that we published in the Journal of Orthopedic Research. It won the Clinical Paper of the Year award that year at JOR and ORS. And basically the same exact thing using meta-analysis. What we did was a meta-analysis of all the meta-analyses in the literature, sort of as I jokingly call the inception analysis. Basically, if you look at Cochrane reviews, it's actually called an umbrella analysis. So it's a meta-analysis of all the meta-analyses in the literature. Exact same figure, 50% for all ACL injuries, 67% for non-contact ACL injuries in females. Across the board, this is doable. For JOSPT, for the American Physical Therapy Association, same year, later that year, we published this massive compendium, and basically that's the one that gives you all the different programs and it shows them to all be effective. It's actually amazingly striking. In my decades of work in the fields of orthopedics, cardiovascular sciences, sports medicine, the effect size, that huge, is unheard of. And not only that, is it's very, very consistent. The group, and one of the groups in Germany did a analysis which showed a funnel plot analysis that showed all that data hugs a line right between 50% and 2/3, right on the line. And none of that data goes out the funnel plot, which shows this is not a positive publication bias. The challenges are multiple. The challenges are compliance, especially by the coaches. So a student of mine named Dai Sugimoto, who's now up there with Lyle McKaylee and the group in Boston, basically showed that coaches are the toughest ones to get to comply with this training. We also showed with that series of studies is athletes want to be adherent. They will be adherent. They will do it if it's provided to them, but very often it's not. And very often it's dropped. Here's the thing. So we developed the first program. Do you need to use my program? Absolutely not. If you have one magic bullet, and I'm going to say, because everyone wants that one magic bullet, what you do is teach an athlete to decelerate on their foot with their center of mass centered stably over the plantar surface of their foot, with their hip and their knee in a stable flexed configuration over that foot. And you do that repeatedly with plyometrics, jumps at maximal effort, and then you take that out onto the field and you do drills, calisthenics, warm-ups that incorporate basically that idea into multiple exercises, which should only be about 15 minutes, 2 to 3 times a week prior to practice, and it's going to work. The big challenge is getting people not only to do it, and the Norwegians showed this. They showed the same risk reductions we did, but then they took their physical therapists away from their teams. So they said, okay, coach, we can't afford to have these PTs taking your players through this every week and every day. So we're going to hand this off to you. Their ACL injury rates went right up back to where they were before. And then they put the PTs back in, actually doing the exercises, making the coaches compliant. The athletes are happy to be adherent, and they drop that risk profile. And I've worked with many sports teams from pro, college, high school, junior high school, elementary. I can tell you that is elementary. You have to have buy-in and you have to have compliance for any of these programs to work. But pretty much most of those out there are going to do the same job and get you that same level of risk reduction if they're properly and religiously applied. Any other questions?
Yeah, hey, Tim, Simon here. I apologize. I had some car trouble. I missed the beginning of your talk. Thanks for being here.
No, you didn't miss much, Simon. Don't worry about it.
Yeah, sure. As a follow-up to that, with some of our physical therapists and other clinicians here that work with adolescent athletes and just in terms of neuromuscular plasticity and taking this kind of like through the growth and maturation, skeletal maturation. Do you feel that the need for reinforcement changes after those things kind of become ingrained, or do you feel like all these athletes would still benefit from kind of tune-ups and having this incorporated into their daily practice?
Yeah, so this really was the PhD work of Kevin Ford, my student who worked with me at Cincy and was down with Christian at UK. And basically what we showed, this was multiple serial longitudinal studies of that entire cohort. What we showed was at the time of peak growth velocity, when kids hit adolescence, that's when they go from very low risk to very high risk. They go from very low knee loads, especially that valgus load, to very high knee load. And that's when you need to intervene. So that's younger and younger and younger. Obviously, this is dropping in girls, actually rather unnervingly fast. It's basically in US female populations, it's around age 10 or 11. In boys, it's a couple years later. So we're talking about age 12 to 14 in boys. And that length of area of risk is actually longer in males, very often because they play sports longer. But my answer would be, you need to get them early, and you need to get them often, and you need to do it religiously. Because basically we also showed in the lab, because we would bring these kids, test them, train them, bring them back another year, year after year after year. What you see is you'll get a risk reduction of, say, they have a Newton meters of valgus torque of 50, and then you bring that under the risk line, which is 25. You can bring that down, but then you see it creep back over the off season. So yes, they need to religiously repeat this training on a regular basis.
Thank you.
You're welcome. No one wants to start up any real fights. We don't want to have any fisticuffs here. Let's throw it down. If you don't want to do it now, let's do it on Twitter.
Well,
Tim, anytime.
So I don't do the Twitter thing, but let me ask you a question. And this is really more kind of a real life kind of advice, right? Mm-hmm. So we have been pretty busy here, starting to implement 2 high school outreach programs, and we are basically kind of in the process of streamlining a lot of those to the point where you could implement those kind of programs across many high schools, not just based upon individual efforts. Any tips or tricks that you have seen? You have talked to people worldwide about these kind of issues. Any tips or tricks? What works? What doesn't work? To kind of just basically implement this in a better way. You've alluded to what the Norwegians do with the PT on site. That's obviously not sustainable here.
Right.
But how would you go about it if you were to start out de novo in a new state, and you can have what you need and what you want? How would you do that?
So the first thing you need to do is find internal champions. So champions within that school who are going to bring money, who are going to bring motivation, who are going to bring concern for this, and are going to be open to learning. And that's education is a huge part of this. So normally what we've done in the past is, sadly, usually when we're called in, is there's a big rash of ACLs in the school district. So I can just say this, I can give you an unending number of examples, but those that have had a huge surge in ACL injuries, those schools we've kept our relationships with for decades. Because they know how bad the problem is. And at the higher levels, the US ski team, where 35% of their skiers have all had ACL injuries, it's not that difficult to get this ingrained. However, at a school level, say where you want to get ingrained, say in the junior high school or even high school level, and say, for example, they haven't had a slew of ACL injuries, what you're going to find is usually it's going to be an assistant coach, a strength coach, someone, even a parent who's had very often 2 or 3 or 4 ACL injuries. So those people who are dual ACL injuries and reconstructions, that first ACL injury is a challenge, physically and mentally. The second ACL injury becomes it becomes such a psychological aspect of their personality that it becomes ingrained, and they become extremely motivated to prevent this from happening to them and anyone else, especially if they're coached somebody on their team. So very often that's where we've had the best chance at inroads, is with someone associated with the team. Very often it's an assistant coach, or the problem with the head coach often doesn't have time. So very often it's an assistant coach that helps us get that ingrained in the system. And then once it's ingrained, you use those people, you get support. For example, we had many school systems, Galesburg, Illinois, Madeira, Ohio, where we went from, so they had a slew, say on their basketball, well, Galesburg had in one season 6 of their athletes on their basketball team go out with ACL injuries. Madeira High School had a slew on their soccer team, and we got a coach, a couple parents that didn't want this to happen to their kids, or if it had happened to their kids, they didn't want it to happen again. And then we got it ingrained to where we were coming back year after year after year. And if we couldn't do that, for example, in both of those, we got the school board on board, as we did in Boone County as well, and actually got boosters of their athletic programs to pay for them, or for us, either for us to bring them to our facilities or for us to go out their facilities, train them, and then over time, train the coaches, train everybody, that's related to the program with the proper techniques, and make sure there's always 1 or 2 or 3 people, parent, athlete, coach, that's going to keep this going on year after year. But it is a challenge. I recognize your challenge. Other questions?
Yeah, Christian had to sign off. We're coming up on the top of the hour. Tim, I appreciate you especially jumping in late. We had a cancellation, everybody, and Tim was gracious enough to jump in and give us a great talk here, great synopsis on all this, on his body of research. It's very impressive. We're opening the Sports Performance Center here, Tim. When this whole COVID thing blows over, we need to have you out here and get your blessing here.
I'm very much, I've had several Zoom meetings on the occasion, but I'm really looking forward to doing things in person. It's always more effective, as you well know.